how about this? Let's do central lines. Because again, this is going to be, you're going to have to do this in the near future. Okay, so where do we place central lines? Central venous catheters?
IJ.
Okay, IJ.
Femoral.
Okay, femoral. Subclavian. Okay, so internal jugular, femoral, subclavian vein. Which one theoretically is like the least favorable? Femoral because of infection. But which one is done in a crashing code type scenario? Femoral, okay. If you had to choose and it wasn't a code-like scenario, what do you do to help you make sure you're in the right spot?
Ultrasound.
Yeah, so you use ultrasound. So we do ultrasound to help us, okay? When you're using an ultrasound, say we're doing an IJ, and you're looking and you see this. What is that?
One's here, one's an artery.
Yeah, so one's your carotid artery and one's your IJ. With the ultrasound, what do I do to delineate those two things?
Compress down.
Yeah, we push on it and compress it. So when I compress this, this turns into nothingness, the vein, and then this gets smushed but is pulsatile, okay? I was talking today. So now on the ultrasound, the vein is here, and I look at my depth on the side. And this says here 2.5 centimeters. Why is that important to me?
You start 2.5
Yeah.
centimeters.
Yeah, Ryan got my little spiel today. So this is 2.5 centimeters to the center of the vessel here, okay? So in theory, my ultrasound probe is here, and I'm looking here, and it's 2.5 centimeters. I want to go 2.5 centimeters back from that probe, and then I want to go in at 45 degrees, and then I theoretically am going to land smack in the middle of that blood vessel. What's that called? Geometry style?
Oh, the Pythagorean
Yeah, the Pythagorean theorem. It always comes back to bite you. So that is how we help and utilize the ultrasound. So, all right, we get the stick. What was the other little pro tip I gave today about, say you have the needle, what type of syringe?
Yeah, the slide off.
You want to use a slip tip syringe. You don't want a syringe that has like a screw top to it, if possible. And you want to use a 5 cc or a 10 cc syringe. You can't use a massive syringe because you can't pull back on the plunger. Okay, so the slip tip thing is because once I get in to the vessel, now I'm like freeze, like everything freezes. So if I don't have the slip tip, I have to unscrew the syringe off. Versus the slip tip, I just boop, pop it right off. So then I have the needle in the vessel. What should I see?
Dark. Blood.
Dark venous non-pulsatile blood. Okay, good. We're doing good so far. What's next?
Put your wire.
Oh, wire.
Wire. So again, these are all Seldinger techniques. So now I thread my wire. Okay? All right, everything's good. What do I do next? I make a little skin incision. And like I said, you have a wire in an incision. Sometimes you get what I call a skin bridge here. So you need to make sure that there's no skin bridge near your incision. Okay? Then you dilate. And like I said, when you dilate, you push from here, not from here. If you push from here, you're going to kink your wire. It's just like a tree branch, like a twig. The twig's going to snap here. It's not going to snap here. Dilate, wiggle the wire. Dilate, wiggle the wire. Then you get your catheter in where you want it. Depending on where you put it depends on what? What do you have to be cognizant of? If I put it in my right IJ versus my left IJ versus subclavian versus right subclavian.
Location of the right atrium.
Exactly, the length of the catheter. Because where do I want the tip of the catheter?
Right atrium. Like right before the right atrium.
Yeah, the junction there, okay? The SVC right atrial junction, okay? So it depends on the patient's body habitus and where I'm going. So I need to think about all of these things, okay? Then there's one other important part I didn't talk about today at all. The catheter kind of looks like this, and it's got two things here to suture, and then there's this other thing that you clip onto the catheter that also has some suturing areas. Actually, excuse me, it only has two. like this. So I always tell everybody, these sutures here are attached to the catheter itself. So you put a stitch here and a stitch here. This thing is not actually, you clip it on after, once you're where you want to be. So sometimes people will just put sutures on this thing, and guess what? Seen it. So anytime you place a central line, unless you're hubbed, like in the groin you could be hubbed here, and you don't even use this, then you just do 2. But anytime in the neck or the chest, and when you have this little guy, you need 4 sutures. That's like another one of my big pet peeves. All right, so you put the line in, and what do you order? Put a right IJ in. Chest x-ray. Because what are my complications?
I mean, you could go too far.
Arrhythmias from
Okay, arrhythmias, sure.
bleeding,
Bleeding, sure.
death.
Death, always.
Air embolism.
Air embolism, yeah.
Infection.
Infection, so that's called a what? Central line associated bloodstream infection. CLABSI, very bad. Again, you guys are missing the one I want you to say. For subclavian and an IJ, not ephemeral.
What else did we not say?
You stuck the needle in too far and you went into the chest.
Pneumothorax.
Pneumothorax, thank you. Happens. Pneumothorax. Very not common, but happens after an IJ or subclavian. All right, central lines. You're going to do one soon.